The next session is our physician panel centered around the idea of improving epilepsy care through effective patient-physician partnership. And the idea behind this is that our organization often gets calls from people who are newly diagnosed with epilepsy, or maybe they feel that they want to seek another opinion. And in either situation, they may be, meeting a doctor or starting to work with a doctor that is new to them. And so, having some strategies and tips for just making sure that that's going to be an effective relationship, from the doctor's perspective and from your perspective, is an important thing to talk about. So we are very lucky to have two providers who care for epilepsy patients here with us today to share their perspectives to a series of prompts that I will provide them. Dr. Richard Simmons of the Child Neurology Group will provide his perspective as a pediatric neurologist, and Dr. Amber Mitchell of Nuvance Health in Kingston will provide her perspective as an adult neurologist. She also does treat some pediatric patients, but adults as well. So to more formally introduce our panelists, Dr. Simmons is board certified in neurology with special certification in child neurology. He completed his undergraduate education at Union College and attended medical school at the Drexel University College of Medicine in Philadelphia. He completed his internship in pediatrics at the Robert Wood Johnson University Hospital in New Brunswick, New Jersey. His neurology and child neurology training were completed at SUNY at Buffalo and the Women and Children's Hospital of Buffalo, where he spent his final year as chief resident of neurology and child neurology. He moved to the Capital District in July of 2009. Lives in the Clifton Park area with his wife and his own children. And he's an active member of the American Academy of Neurology, the Child Neurology Society, and the American Epilepsy Society. He also serves as a member of our professional advisory board here at the Epilepsy Foundation of Northeastern New York. Dr. Mitchell is a neurologist and epileptologist and is board certified by the American Board of Neurology and Psychiatry. She is also board certified in epilepsy. Dr. Mitchell provides specialized neurological care to adolescents and adults age 16 and older with seizure disorders and other conditions such as migraine, movement disorders, stroke, and memory impairment. She has a strong interest in the diagnosis and management of patients with seizures. Dr. Mitchell is the founder and director of the Epilepsy Monitoring Unit at Northern Dutchess Hospital. She completed the highly competitive accelerated 7-year combined medical degree biomedical research program through Rensselaer Polytechnic Institute and Albany Medical College. She is originally from the Hudson Valley and feels fortunate to serve her community. And so we feel very fortunate to have these two doctors with us here today to share some of their perspectives. So Dr. Simmons, I see you already have your video on. Dr. Mitchell, I invite you to turn your video on as well and to unmute yourselves, which you should be able to do on your own. Okay, very good.
Muted.
Yes, I can hear you. Very good. Thank you, Dr. Simmons.
Can you hear me okay?
Yes, Dr. Mitchell. Yes, I can hear you great. Thank you so much. So again, thank you both for being here. And as I described earlier, I'm going to just sort of go through the prompts one by one and invite each of you to share your responses to that. And if anyone has questions as we go, again, feel free to use the chat. So if you have a follow-up question to something that's being discussed, feel free to send it to me in the chat so that we can, add that to our discussion as this, obviously these sessions are for those who are in attendance today. So we want it to be very valuable to you. So our first prompt for this session, describe what your expectations are when you are establishing a relationship with a new patient. For example, what kind of information should your patient bring to the table, and what is most helpful and what is least helpful? And Dr. Simmons, let's start with you.
Okay. So we're going to have different answers, obviously, because we tend to deal with different populations. In my world, the overwhelming majority of patients who show up to the office come in with at least one parent or guardian. So as an information provider for a pediatric patient, we'll often start, or I often start at the beginning. When we're talking about seizure disorders, there are a number of variables that we have to consider when trying to come up with, an initial diagnosis and treatment strategy. So I tend to start at the beginning, which is I need to know as much as I can about the patient's birth history, pregnancy, labor, any medications that were taken during pregnancy, any testing that went on. Were there any developmental issues? Was there any support provided through early intervention? Does the child get any services through their school, depending on their age? How they're doing academically? All of these things factor into a picture of the child as a whole. And then when we start to talk about the presentation of seizures, which is usually what brings them to the office, as much information as possible is important. Unfortunately, we get a lot of parents who come in after the child's first seizure, and as many of you are aware, that first seizure and even the 50th seizure can be panic-inducing events. And so coming in with a scattered, unclear memory of the event is not uncommon. And we do the best that we can with the information you've provided. How long the seizure was, what the scenario was, where was the child, how the child slept that night, what time of day was it, what were they doing, how did they do after the seizure, did you go to the hospital, what hospital did you go to, what testing did they perform? So all of that information that kind of comes at you, like it's shot out of a cannon, is important. So if something happens, do your best to take your phone out, take a piece of paper out, and record things, because you're going to forget a lot of details of who you saw in the ER. Did you see neurology? Did they come down? Did they do any testing? What happened? And parents often forget because it's an overwhelming experience. So taking notes is incredibly important for that first seizure. And then, if you've seen anybody prior, if you're coming in for a second or a third or a 15th opinion, knowing who you've seen, what testing they've performed, and any records that you can bring in with you or have sent in advance is incredibly helpful, because we don't want to repeat testing if it's just been performed 2 months prior. But we also want to make sure that everything that we would do has been done. If there's no MRI that's been performed in the last 5 years, we may want to order that up. So, that's what I find helpful from patients. And, we'll pull information from you, and you're going to come back and see us. So, if you don't have answers, jot them down, go home, find them for us, and then bring them back to your follow-up.
Thank you so much. And Dr. Mitchell, what do you think about this?
You can hear me okay?
Yes, we can.
Great. So everything Dr. Simmons said is pretty similar to adult neurology. It's very important if you have a family member that has a cell phone or a video, to record the seizure. If this is a recurring problem, that's very helpful to have a family member record it and or come to the visit and describe exactly what's happening during the seizure. Because many times patients don't have any recollection of what happened before, during, or after the seizure, and they're unconscious. So the family is really important to come and be an eyewitness about what happened during the event, or to provide the video. And the ancillary information is also very important, like whether they went to the hospital, what the ER did, whether they ran blood work, whether they did an EEG, and any past history, whether they had something immediately before the seizure is very important, whether they accidentally took too much of the medication, whether they drank too much alcohol. For the adult world, a lot of young teenagers or adults who go into college, they start drinking and partying, and then the next day or that night they have their first seizure. So the history behind what they were doing the day before and the day of is very important. Whether they had any concussions the week before or years before is important. So yeah, the history is really important. So having family members come with them is definitely a plus.
So would either of you say that there's too much information that new patients can provide, or, you know, the more data, the better?
Probably the more data, the better.
Yeah, I would agree with that. You know, come with everything you think is important. And we often guide the conversation because we tend to like a linear story, and patients come in and often just want to tell you everything all at once. And so being patient with our process is important, recognizing that most physicians have an order that they like to gather information in so they can have a nice, clear, linear story in their mind. Because a lot of patients come in, for example, I had a patient this morning who came in and started telling me about the emergency room. And I had to pause them and say, hold on, let's go back. You know, what happened to get you to the emergency room? What's happened prior to that? Let's start the story. And so cooperating with our recording of the story is incredibly helpful for us to be able to go back. When you come in again, you know, I'd love to tell you that I remember every patient, but I don't. And so if I have a nice, clear story that I've written for myself or for another physician, it makes it much easier to remember what happened and then be able to move on with our next appointment.
Awesome. Thank you so much. And are there any specific strategies that you'd recommend patients use during appointments for effective communication and understanding after the appointment? So, you know, letting, you know, the physician sort of guide the conversation can be helpful. But other tips that I've heard given to patients are things like writing questions down before the appointment, maybe even sending questions ahead of time in a patient portal. So, you know, the physician will know, you know, what it is that they want to address during that appointment. Do you agree with that? Are there other specific recommendations that you would make in terms of facilitating that better communication? And Dr. Mitchell, let's start with you this time.
Yeah, that's a good point, because many of these patients, their memory is not the best, or they're overwhelmed by coming to the doctor and being rushed. So I encourage the patients to write all their questions down between appointments. And sometimes there are family members who have questions and they don't want to ask it in front of the patient, but they're on their they're allowed to speak with me through HIPAA, and they send me questions through the portal, or they email me, or they speak with my nurse ahead of time and give me a heads up on specific things like, oh, my husband is drinking excessively and he has seizures related to this. Can you address this at the next appointment? So yeah, I encourage the note taking, because sometimes we get so set in how we have to go through our history taking that the patient forgets to ask their questions. So then I usually ask at the end of the appointment, do you have any questions? And then they have their question sheet out to go through all of them.
Yeah, I would agree with that. Having a question sheet, even if you have them all memorized, having a bright yellow piece of paper with all of your questions written on it and held there in your hand is a visual reminder for me at the end to say, do you have any questions? Because I have my own agenda during that visit, and it's pretty easy to get sidetracked and fixated on the 14 things that we're planning on doing and have to move out the door. So having a visual cue to remember to address all of those questions is important. So, and don't be afraid to yell at us too, in the nicest way, and say, hold on, I had a few more questions. Because, we're human, we're busy, we see a lot of patients, and we're sometimes ready to move to the next patient and, grab us and stop us. That's how you're going to get your questions answered.
Awesome, thank you. And I've also heard it suggested that sometimes a patient can maybe ask for extra appointment time if there's going to be, an issue that maybe requires longer conversation. For example, maybe wanting to become pregnant, or discuss a medication change, or discuss a non-drug treatment or something like that. Is that something that is reasonable to do, to call ahead of time and say, hey, if we can schedule extra appointment time, so that we can discuss this, I'd like to do that? Or is that just sort of not possible these days? I know you guys are busy, so.
I'll typically have an extra 15 minutes added in if in advance, if the patient makes us aware that, or the patient's parent makes us aware that, hey, we have a number of questions, it's a new diagnosis, or what have you. The goal is to make sure we get all those questions answered. And then once we hit that initial wave, we can go through the portal, or we can ask them at follow-up appointments. But yeah, the occasional extra time for conversation is not unreasonable.
Awesome. Thank you so much. Can you discuss the importance of patients being open, honest, and upfront about medication adherence, other health issues that can influence medication adherence, like different habits that they may have, or challenges that patients have had with medication compliance? And Dr. Mitchell, let's start with you again for this one.
Yeah, that's very important, because there's a large percentage of people who are just not maliciously, they are non-compliant with their meds. They just forget, their dose to take meds 2 or 3 times a day, and they're working and busy, and they forget to take their medications. And that's very important, because we could have someone who's not seizure free, and they come to us, and it's important for them to be open and honest that they're not taking their medicines regularly, because that could be the reason why they're not having a good response to the medication. The way we work around that is we sometimes just check medication levels, and then we can tell that the level's low, and it can be evidence that they're not taking their medications. So that's one of the reasons the doctors like to send you for medication checks, level checks. And other things in their life are important, such as whether they work overnights. I have a few patients who are in the healthcare field, and they work overnights, and they have more seizures because of the stress of the day. The day-night cycle is disturbed, and they're not getting enough sleep. They're sleep deprived chronically, and they have more seizures. So that's important to know. Whether they do any recreational drugs or drink alcohol is extremely important to know, because sometimes those are the reasons why they're having more seizures. And if we counsel them on doing less of those activities, that can help their seizure disorder. Whether they have stress in their life, whether they're depressed and on specific medications for depression or bipolar. That's important to know, because some of those medications can make patients with epilepsy have more seizures. Mm-hmm. They lower the threshold. So it's important for us to know the whole social picture, the whole medication picture for patients, for us to give them the best care.
So I imagine that that's another reason, to your point earlier, that it can also be really important for like a loved one of a patient to also communicate with the doctor separately, because perhaps the patient themselves is, afraid to admit, that, oh, maybe I, enjoy to drink alcohol, and, sometimes that might contribute to me forgetting a medication or something like that. So, having someone else be able to contribute to that story can be helpful, so that you do get that clearer picture. Mm-hmm. And Dr. Simmons, I imagine this issue is, a little bit different for you, because often it's parents who are helping their child stay on top of medications. And so, medication adherence is not really up to the patient alone. It's up to, the parent or guardian who has to help them with that. So what's your perspective on this?
So we have, we've got 3 basic age ranges. We've got little kids whose parents are in complete control of their medication administration. And so I talk to those parents as a parent and say, I have 4 kids. I don't think that I've ever completed a full course of antibiotics without missing at least 1 dose with all of my kids. If we do, it's like worthy of celebration. And so I say, listen, I understand that we miss doses from time to time. You know, there's 14 different activities on Saturday morning. Somebody got up late and everybody ran out the door. But if we find that medication compliance because of scheduling or because of patient refusal, we have little kids who spit their meds out, who don't want to take their meds. And the parents are worried that, you know, they're going to look like bad parents because they can't get their kids to take a medication that tastes awful. So I always want to tell parents, I expect you to screw up just because I screw up and everybody I know as a parent screws up on a regular basis. So I want to know you've screwed up and how often, and then we can address it. We can see if there's other ways to get around it. So the next bracket of kids are the kind of tween, teen, mid-adolescent kids who are beginning to get some level of responsibility. And so oftentimes those parents, or sometimes those parents, will allow their child to take their own medication. And I'm okay with that. However, I usually recommend that parents use, if in that situation, parents use a pill box. So they have a visual reminder that their child has or hasn't taken their med that morning, rather than just hand them the bottle, because unless you're counting every day, you're not really going to know if your kid missed their AM or PM dose. And that's also the age range where they start to get weird in terms of their sleep. They like to stay up late. They have a rough time getting up and getting moving in the morning. And then on weekends, they tend to sleep in. So if you're dosed on a 12-hour schedule, 7 and 7, that's fine for school days because there's a good chance they're going to be up at both of those times. But when they sleep until 11 on Saturday, then they're taking their medication 4 to 5 hours later than they normally do in the morning. And then maybe messing up their evening dose because they're out with friends on a weekend. We have to really try to reinforce, like, your medication needs to be taken consistently. So lay it out, set an alarm, wake up at 7, take it, and go back to sleep. And then in the evening, if you're going out with your friends, if you don't think you're going to be home, take it with you, set an alarm on your phone, or have the parent text the child to remind them. And then we have our teens, high school age and beyond, who are doing things primarily independently, or a lot of them are. And the same issues pop up, but we also get into a little bit of an age-related frustration, depending on how long they've been diagnosed, an age-related frustration because of some of the restrictions that get put into place because of their seizure disorder, because of the frustration with their diagnosis in general. And we'll sometimes get kids who just don't want to take medication. We'll frequently find that out when they have a breakthrough seizure and we check a blood level and it's 0. But I try to be upfront with patients and say, I know this is terrible. I know this is not fun. I know that you can't do everything that your friends can do. But the only way to get as much freedom as you can is to be compliant with your medication and be honest in the office visits. And so I appeal to them more as adults because I think that they take that to heart more than being treated like a sick child. But those are the kids that we have to watch out because they're staying up until 3, 4 in the morning sometimes, and they're sleepovers, and that's when they're going to start experimenting with alcohol and drugs on occasion. And so that conversation, as weird as it feels, needs to come up much earlier than we anticipate. A lot of us save it until they're heading off to college, but I prefer to do it when they're in their sophomore, junior, senior year, asking about it, talking about it in very kind of general terms, so as to not sound accusatory. But it happens. The best students do it and the worst students do it. And so assumptions aside, I like to put that out there as well. And I say to patients, once they're old enough, I say, if you want to talk about anything without your parent in the room, we'll have mom step out for the last 5 minutes or 10 minutes and you can spill the beans. And that usually helps as well, because then they don't feel like they have to hide the fact that they've been, they've had a couple of beers at a party, or they smoked pot a couple of times, and that helps them get comfortable being open about those kind of things in that setting, and then maintaining that confidence makes them more likely to tell me if anything's going on once they start to become more independent as adults.
Awesome. Thank you. Thank you both so much. The next item, which I think that both of you have touched on a little bit, but what are the health issues that are most important for patients to bring up in appointments, especially if their neurologist doesn't make a point to ask about them? So things like stress, anxiety, nutrition, sleep issues, fatigue they're experiencing. So maybe some of these non-seizure related experiences that they're having with their health. Dr. Mitchell, do you want to take that one first?
Sure. Yeah, so whether patients are on other medications from other doctors, that's important, because sometimes patients come from other medical groups or systems and we don't have all of their medications in our system. So just going over the medication list thoroughly is important. And part of it, some of the adult patients I see, unfortunately, are on chemotherapy or other strong infusion therapies for arthritis, immunotherapies, and some of those can have drug interactions with the seizure medications. So just knowing every part of their healthcare is important, whether they're getting radiation therapy to the brain for something else, to the neck for head and neck cancer. Everything is important from our standpoint about their other outside care. Whether they have stress, whether they're on psychotropic medications for depression, anxiety, those medications. Some of those medicines like Wellbutrin, which is a common antidepressant, that one can lower the seizure threshold, which means it can make someone with epilepsy have a higher chance of having seizures. It could also make someone without a seizure disorder have a seizure, because of the way it works on the chemicals in the brain. So the psychiatric history is very important from our standpoint. And just their overall family dynamic and social situations important, because any emotional stress or stress in the household can trigger more problems. So it's good to know their social dynamic, and you can try to get them help for that if you know about it, what's going on.
Awesome.
Yeah,
Dr.
I would agree with that. So in the pediatric population, it's sometimes easier to identify mood issues when you've got adults in the household who are interacting with these kids on a regular basis. So it's much easier to pick up on, the crabby teenager who wasn't so crabby before medication, or the middle school student whose grades have gone from straight A's down to B's and C's or even D's. And that's something that I tend to bring up in every visit. How's school? How's their mood? School is a great indicator of mood for a lot of kids. When we see things like depression and anxiety that may pop up because of the seizure disorder, they may pop up because of the medication, or they may pop up just because they do pop up. That's a good cue for us if their grades or performance is dropping, or their interest in school is dropping, to look into that a little bit further and see if it's something we're doing. For example, there are seizure medications that can change patients' moods dramatically. To decide whether or not we think it'd be reasonable to try a different medication, try a different supplement to see if we can perk their mood up, or to refer to psychiatry or counseling or whatever to address the issue. But it's the older kids that are often confusing. We have parents who are like, well, I don't know if, she's 15, they're all crabby at this age. But I said, was she crabby a month prior to starting medication? Well, maybe not as much. And so paying attention to those kind of changes are important, or is important rather, because that would point at either the diagnosis or the seizure medication as possibly being the culprit behind a mood change. And that's something that none of us want to do. We don't want to create a new problem because we're fixing an old problem. We want to try to keep the child where they are and make improvements. So I always bring up their mood, and I always want parents and the patient specifically to be as honest as they can about how they feel.
Thank you. And speaking of school, the next prompt actually is specific to school. And I know, Dr. Mitchell, you also treat younger patients, so feel free to chime in with this as well. But how can and should parents help facilitate effective communication about what goes on at school, including services that their child receives and plans that are in place, such as the seizure action plan, IEP, 504? And what is your involvement with the schools? Do you ever communicate directly with them, or is it usually through parents? If you can share a little bit about that.
So it's variable. There's not a uniform answer to that question. So I have participated here and there in meetings with schools in terms of how best to deal with confusing seizures or multiple different seizure types in a single patient, when to administer emergency medications. We answer these questions on a regular basis. Do they need their diastat on the bus? Do they need to take it in their bag on, on soccer, travel soccer games? So those are the kind of things that we'll talk about with the school. But some parents are hesitant to inform the school. And I always encourage them, be as open as you can with the school, because they don't want to be sidelined with an unexpected seizure and have no idea what to do. So we try. August and September are usually chaos here because I have stacks and stacks of seizure action plans to fill out. So being ahead of the game in the summer to develop a seizure action plan for your child, if we're approaching the next school year, is important, to make sure that we have updated medication on hand, that the dosages are correct if the child has grown over the past year, and that the school has all the information they need in order to administer emergency and rescue medication. But we also try to have parents be in communication with the school psychologist, because we do see elevated rates of, as we talked about, mood issues as well as learning disabilities in some patients with epilepsy, things like processing disorders and ADHD. That should also be addressed and sometimes get dismissed because the epilepsy steps into the limelight. So open communication with their teacher or teachers. The school psychologist is a better go-to when the kids get older and they've got 7 or 8 different teachers that they're seeing throughout the day. So I don't uniformly give patients IEP or recommend IEPs or 504s. I typically reserve those for patients who may need extra support or do need extra support in school, because we have some kids who have seizures only at night. Well, that's not going to have a major impact on school and doesn't seem to impact their academics. Then I'm not going to advocate for a 504 plan for that child. But for many kids, having the 504 with some lenience if they have a seizure and they miss school and they miss a test, that they don't get a drop in the grade for a makeup or anything like that. So we just try to make it as accommodating as possible, because most teachers, but not all, are empathetic and forgiving. And so we want to make sure that we have protection in place for maybe the salty science teacher who doesn't care that you were absent, you missed the test, you automatically lost 10 points. So that's, from a school perspective, that's usually what I do. And then we have, as I'm sure they have or will talk about, the Epilepsy Foundation will do education and in-services for the schools as well, to make sure that everybody's up to speed in terms of, what services they can offer.
Yeah, thank you. Dr. Mitchell, do you have any thoughts to add?
Yeah, for older patients who work, some of these patients, they need protection against being firing and for having to suddenly miss work because of a seizure, or having to, for family members, sometimes they need to leave their work to care for their family member with a seizure. So it's important to fill out FMLA paperwork for your job, and that's a level of protection against getting firing or any discrimination that can occur. Also, some patients who are in college or in school, sometimes I just write like a generic note explaining the patient's condition and what to expect, and kind of similar to a seizure action plan, to inform the school about the seizure, what to do, and who to call. So that's important, to just inform the employment or the school that there are seizures, because it could be a dangerous situation if a patient has a seizure in the school or the workplace and there were informed that there was a seizure. So it's important to inform everyone that the person who you're treating has a seizure problem so that they can act and get the patient help, call 911 quickly, call the parents and administer emergency meds like Diastat. And there's a few other newer ones that came out like Valtaco and nasal sprays to help stop the seizures from progressing. So they're like acute treatments. So I encourage being more upfront with the workplace for patients.
Excellent, thank you. And you know, just if there's anyone on this participating today who is not so familiar with our agency, as Dr. Simmons mentioned, we do offer training. So we do professional in-service training on epilepsy and seizure first aid and seizure recognition. And we also, you know, do training in schools. So for school personnel and also for students, so that, you know, classmates are able to better understand and, you know, have knowledge of what their peer is going through who's living with epilepsy. So if anyone is interested in taking advantage of those programs, it is by request, free of charge. You know, I set up the training, and you can feel free to reach out to me by email, which I will provide in the chat during our lunch break for anyone who might be interested in education. Okay, so our next prompt is sort of a very specific scenario, and I don't really know how often this happens, but thought it was important to bring up, you know, just in case you have any good advice. So you know, what advice can you give to patients who have some sort of medication or other issue come up? Perhaps, for example, a side effect after a medication change, but they don't have an appointment with you coming up. And, you know, even more specifically, maybe they're going into a weekend where their doctor's office is closed. You know, what advice can you give for how to handle a situation like that? You know, for example, you know, should they reach out to your clinical support staff? Could they go see their pharmacist and ask them about what they're experiencing? Like, what kind of advice can you give for a situation like that were it to come up? Dr. Simmons, go ahead.
Oh, okay. We're in a little standoff there.
Yeah, sorry.
So any side effect, something we want to know about. And most of us, you know, we're accessible 7 days a week after hours. You know, we share call on weekends, but I tend to cover most of my patients or all of my patients during the week. So if something comes up during the workday, call into the office. If it's something dramatic and you know, severe, obviously make sure that when you speak to one of the secretaries that it's, you know, it's made clear like this is, you know, this needs to be addressed right now, because we get a ton of questions on a daily basis. And sometimes we don't have enough time to address every single question by the end of the workday. So if it's an emergency or you're really concerned, you know, push that issue with the receptionist or the secretary you're talking to. Same thing on weekends. We're on call for a reason. If there's a dramatic side effect, call. Most of us have the ability to send prescriptions from wherever we are. If we need to change a dose, if we need to change a medication, we can certainly do that fairly easily after hours. So I would say, you know, talk to us. Pharmacists certainly serve a role, but we have clinical experience that's different from a pharmacist. They have a textbook, but we have, you know, kind of the real world day-to-day experience that sometimes is a little more useful in a situation like that. So I would say call your neurologist if there's any side effect at any point that you're concerned about, and we will usually address it pretty quickly.
Yeah, I totally agree. If there's any side effect, we should be informed immediately. I have some patients who are quieter and very shy, and they think, oh, they have to take this medicine until the next appointment, which is 3 months from now, even if it's making them sick. And, you know, I had to counsel them, no, you have to just let us know anytime after hours. There's always somebody on call, and we'll probably tell you to stop it. Some of the side effects from the seizure medicines can be life-threatening, such as there's a very lethal rash called Stevens-Johnson syndrome, which could occur with certain seizure medications such as lamotrigine, zonisamide, and other medications. And that's a very severe rash that's almost like a burn that can occur around your mouth and on your hands. And any rash that occurs with the seizure medication, that's considered a serious side effect because of the concern for that rare condition that can happen with seizure medicine. So you should always let your doctor know if you're having any adverse side effect, whether it's mild or severe, because it could be more severe than you realize. And we don't want patients suffering from side effects, because the purpose of the medication is to keep you seizure free, but also so that your quality of life is good. So we don't want you on a medication if it's making you sick 365 days of the year. See, it's a fine balance. We want you seizure free, but we don't want you having all those unwanted side effects. So knowing the side effects is as important as knowing if you're having seizures, because it affects your quality of life. So it's always important to let your doctor know about any discomfort or side effects on medications.
Awesome. Thank you so much. The next one is about monitoring and collecting data on seizures. And I think that we have talked about that quite a bit. So recording things that are going on, taking videos, being very helpful, writing down any questions that come up in between appointments. Is there anything else that you would like to add about, best ways to monitor or collect data on seizures between appointments?
So nowadays, there's a lot of very useful applications on cell phones that you can download, and you can document digitally each seizure that you have pretty easily. So there's applications for that. And some older patients really like to just, with a pen and paper on a calendar, write down and describe each seizure that occurs on the calendar and have it visually in front of them. So there's every generation and every person has kind of a different style, but just having the data in any form is helpful on paper, or whether they remember it, or whether it's on their phone and they show me their phone calendar and all of their documentation of each seizure. So any of those are great resources for us.
Yeah, I found, in child neurology, obviously parents come in with the majority of patients. And we all know that moms are better at this than dads for the most part, but the moms tend to roll in with the book, right? They'll have either, depending on how long the patient's been diagnosed, we have the moms who have like the 3-volume set of binders of everything that's ever happened. And those are useful, but sometimes that amount of information can be overwhelming. Especially at the first visit when they say, I brought everything, and they put it on my desk for a half-an-hour appointment and it's 3 hours worth of reading. But I have found over the years, with all the apps and all the other technology that we have, that a piece of paper is the most reliable and copyable thing that we have. So I can get your piece of paper with all of your documentation and scan it into the chart. I don't have access to every single app, and sometimes sharing that data, the patient holds it up and shows it to me and I go, all right, hold on. And then I'm trying to record that information. So, the mom calendar is probably one of the most reliable means of recording. And those tend to be the most useful from my perspective in terms of documenting and keeping, keeping updates. I have parents who bring in spreadsheets. I have parents who are making like pie charts and graphs and, doing calculus when they come in to figure out. It's overkill to a degree. While it feels like you're doing something, simply documenting when it happened, what was going on, how long it lasted, had we missed any medications, was the patient sick, kind of the, standard stuff is really, what's most helpful for us.
Awesome. Thank you. I think those are really helpful points to make, that sometimes keeping it simple is the better way to go. All Our next prompt, talk to us about your position on patients seeking second opinions. And, as sort of a sub prompt to that, in a situation where provider and patient personalities don't mesh, so maybe that's, part of the reason that there's an issue, what would be your solution recommendation? So just general opinions on second opinions, and then, if it's a personality thing that doesn't mesh, what are your thoughts on that? Dr. Simmons, do you want to take this one first?
There we go. Sure. My opinion about second opinions is absolutely. There's a point when it becomes futile. When I'm your sixth opinion, chances are you've gone through numerous board certified specialists. The odds of you finding something new from the sixth or seventh opinion is unlikely. And while you may not have all the answers, there's a good chance after seeing that many specialists that we may not have a clear answer for you. But if you're frustrated, if you feel like, the personalities don't mesh, you're not getting the right information, you don't feel like you're being heard, you don't feel like progress is being made the way you would expect or hope that it is, by all means, seek out a second opinion. Any one of us who is worth their salt will say, absolutely, let me tell you where to go. Because it's much easier for me to say, this is what I do for a living. There are people who are above me in the academic world who, eat, breathe, sleep, dream about epilepsy. Those are the people I want to send you to. I want you to go to a higher level than me. So I'll make recommendations to ship patients to different, bigger institutions in Boston or NYU, or sometimes to Philadelphia, depending on where they want to go regionally. But none of us should be offended if you want another opinion. And if we are, well, that's a personality issue. And I'm happy to guide you. And I say, listen, if you go out to Boston and they give you the same answer and you don't want to keep traveling there, come back if you want to. I'm happy to, I'm not going to we're not breaking up, we're just on a break if you want to come back. And parents are okay with that. Sometimes we work in collaboration with the bigger institutions for patients who have rare conditions that I'll see once a career. But somebody in Boston has seen it 10 times. Well, listen, even though it's only 10 times, they're still an expert as compared to me. So we'll co-manage the patient. They'll go to Boston once a year to visit. They'll get some updates, some information. Maybe they're doing a research project out there, but locally, I'm the one filling out your seizure action plan. I'm the one refilling your medications. I'm the one who you're going to call in the middle of the night if there's an issue. And that's fine. We want to take the best care of the patient that we can. But we are all human beings, and we're not going to get along with every single patient, nor is every single patient going to come in here and be enamored with our personalities, our office, our staff, whatever. Again, I'm not offended if you think that we're not getting along. I will do my best. Sometimes, we take the wrong approach. We approach a patient in a way that, was intended to be kind of casual and light, and the patient doesn't take kindly to it, and they want a different personality, and that's fine as well. But in that scenario, again, ask. I don't feel like we're a great fit. Who else would you recommend? That's fine. If you go find your neurologist and look them up, there are a few of us who have 5 stars. I think Amber might. A few of us who have 5 stars on all these ridiculous websites that rate us. We have I have I don't know how many, 25 or something reviews out of the tens of thousands of patients that we've seen. Those are the places you're going to find people who tend to have personality conflicts with their neurologist, or didn't get what they wanted, or they had the office staff was rude over the phone. But most patients who want a meaningful relationship with their neurologist or want a different opinion aren't going to go on there and rate us negatively, because we're going to point them to somebody who may fit with them better. So don't be afraid. You're not going to offend us, or most of us. You're not going to offend us. I'm a big boy. I'm not going to cry if you don't like coming in to see me. I'll find you somebody better.
Dr. Mitchell?
Yeah, that's a very good prompt, because sometimes just the personalities don't mix well. Sometimes what happens is they have patient has a friend who says, oh, I go to Mount Sinai and this person's great and I want you to try this person out. And then they say to me, is that okay with you? I want to try this. I just want to get a different perspective. So sometimes that happens. It's not really personal. It's just they get a recommendation from someone else and they want to try something else out. The purpose of all of our being is to get patients the best care. So it won't offend us if you want a second opinion. And sometimes the second opinion reaffirms what we're doing. And then the patient comes back and they say, yeah, you're doing all the right things. I'm going to stick with you and we're on the right track. Sometimes the reason for a second opinion is not related to the way you're receiving care, but it's something outside of medical care. I had a very elderly 90-year-old man who just couldn't hear my voice because my voice is high pitched, and he said, I have to change. So he changed to the man in our group who had a deeper voice. He just couldn't hear my voice. So sometimes it's not a personal reason. It's just not working out. So the second opinions are good, and you can sometimes, like Dr. Simmons says, when you refer to a higher level of care, you access more research and more innovation that we don't have locally, because some of these patients have really rare syndromes, epilepsy syndromes, and there's other things that are available at these larger centers like Mount Sinai. I like to refer to Mount Sinai or Boston. Sometimes they have research that's not available to us locally because they have the research grants through the large academic facility to provide the research medication and the drug through a grant, and the patient gets it through that grant. So sometimes there's a role for referring out to a larger academic facility, and then it helps everyone. We learn, and the patient gets better care sometimes, and then many times they end up coming back to me, and then we continue what was spelled out at that other level of care. So sometimes it works out perfectly for these patients where we're hitting a roadblock and we need a different approach to try to get this patient more stabilized. So it works for some of those patients.
Awesome. Thank you so much. And we have, about 4 minutes left. And I do have a couple more prompts, but I just want to say once again to those watching, if you have any follow-up questions for anything that's been discussed so far, please don't hesitate to put it in the chat. I don't have any in there right now, so I'm going to offer another prompt for our last couple minutes. But don't hesitate to put something in the chat, and we can try to squeeze that in as well if there's any other questions. But I guess the last thing that I'll ask, because this is an issue that we have heard raised by patients who have called, where their neurologist sort of offers them two different paths that they could take with their care. And some patients feel like they're not equipped with medical knowledge to make a decision for themselves or for their child or something like that. And they sort of feel like, well, why is the choice being given to me about which way to go with this? So I wonder if you can discuss your view on this and sort of what you really see the role of the patient is in that care decision-making process. Dr. Mitchell, why don't you go first? Sorry, I keep forgetting to.
So that's another good point. Sometimes, like personally, if I go to my doctor, that is a little bit annoying when they do what you just said. There's two things we can do. You make the decision. What I usually do is when I have two different medications or three different medications that I narrowed it down to, I give them the pros and cons of each. And then I say to them, this is what I would do if I were you. if I were in your position, this is the one I would pick. And then they pick that one. So it's kind of being a little bit more paternalistic and directing them towards it. But at least in the beginning, they have more of a decision-making process. I'm being first on black and white between all three. And then if they're struggling to decide based on the side effect profile, then I say, well, this is what I would do if I were in your shoes. I would pick this one from their perspective as a patient. So that's kind of the approach I take for that situation.
Yeah, I would second that opinion. I will usually, because we have some patients who have, you know, a certain type of seizure disorder where, you know, 5 different medications are reasonable options. And there's not a best one. So I'll often take into account, you know, if I have a child who has a behavioral problem, I'll say, you know, we could use Keppra, but there's a chance that it may increase the behavioral issues, but it doesn't tend to have a ton of other side effects. Whereas if we chose Depakote, you know, Depakote may actually help with some of the behavioral issues, but may cause an increase in weight or hair loss or more sedation. So that pros and cons conversation. And then in that situation, I'll say, I think the Keppra would be worth trying, but, you know, are you nervous about the behavioral side effects? The parent may say, let's try the Depakote first, or so I will include them in the conversation and kind of tip my hand in terms of why I'm hemming and hawing, because there may not be a perfect medication. You know, you may have a child who's overweight, but Depakote would be great, but it may increase their weight, but then their behavior is also not that great. And so Keppra may not be great either. And so what's our third or our fourth option? And so having that conversation is important and saying, listen, we can change this at any time. I think let's, you know, as Dr. Mitchell said, let's try this one. This is the one I think that's going to be the least problematic. But if it gets down to it, we can change it and go in a different direction. And that goes back to one of our earlier prompts of, you know, what happens if we have side effects? They call us.
Awesome. Thank you both so much. That brings us right to 11:30. And, you know, I just want to say thank you so much for your time and so much